Good afternoon. I would like to start the next session, which is again on AF ablation, but it was on new technologies in the morning. And now we are start the session on different strategies, but also with some novel technologies. And because both operators for live sessions are at Homolka Hospital, they will talk from there. So, please.
Hi, everyone. Hi, Dan. Hopefully you guys can hear me okay?
Yeah, I can hear you. We can hear you.
Okay, fantastic. So there's a small change in the schedule, and I apologize for that, because the plan is we want to show this balloon PFA case as one of the live cases in the afternoon session. So because of that, I want to show this presentation earlier, just in anticipation. So what I want to show to you is the so-called OptiShot balloon catheter. It's made by the company CardioFocus, and while the balloon has approval for use with laser ablation, what we're going to show today with pulse field ablation does not have regulatory approval. I should note that this, it's an advertisement, but we did show one live case of this at the PFA Live Case Summit. So if you're interested, please look that up. So here's what the balloon catheter looks like. You can see there's a balloon, and you can see there's electrodes on the outside of the balloon. I'm going to go through this in detail. But before getting to that, there's two key aspects of pulse field ablation that I just want to point out. I know that many of you have probably seen this, but I just want to emphasize this. The first is this. This is, I think, one of the very, very important studies that really helps one understand how exactly contact and proximity matters during pulse field ablation. So this is an experiment where the investigators took this linear PFA catheter array, and then they either touched the tissue, delivered applications, or suspended it above the tissue at various levels and delivered applications. And then they looked to see how deep are the applications. And here's what they saw. So if I just have you focus here on these left pathologic images, if you're touching the tissue, what they saw was a lesion depth of 4 millimeters. If they suspended above the tissue by 2 millimeters, then they saw a lesion that was 2 millimeters deep, indicating that an electrical field of 4 millimeters, as long as it intersects with the field, that's exactly where you see it. And if you suspended it 4 millimeters above the tissue, you see this very glancing sort of lesion touching the tissue. And this is, again, just shows the numbers. And I think that's a really important concept. And what it highlights, I would say, is if you have proximity, you'll get the maximum amount of lesion. Okay. The second point is this, and this is a computer modeling study that was published, I guess, last year. And here, what the investigators did was to model different designs. And you've seen these designs, of course. This, by the way, doesn't include the current balloon, but it includes a number of other technologies: pentaspline catheter, a circular catheter, a focal sphere 9, the large lattice, the flexible spines where you select the electrodes. And then this is one of the balloon-type catheters. It's actually not being used for PFA right now, at least, but I think is the most relevant for us, this balloon concept. And what they did was to model what the electrical field would look like, and they modeled in different ways. And I just want to show you, if you look here, for example, what the electrical field would look like, this is the balloon concept. And you can see what this looks like compared to some of the others, where the energy is spread a little bit more. And here again, the balloon, you would expect to see a relatively narrow band going around at the point of contact, compared to, like, let's say, other designs. And if we look at this quantitatively, if you look, for example, the current required for 90% transmurality, with the balloon, it's the least amount of current that's actually required, because you have that central insulator and all the energy is focused peripherally. Number two, electrode current density at the power, and you can see, again, it's the least amount of density because, again, it's focused right at that location. And not surprisingly, again, because of the central insulator and the way the balloon is designed, the highest percent of the delivered power would be going into the target. So in many ways, a balloon approach really does target to the location. Now, there's a caveat to all this, of course, which is you need to make sure that your splines are actually touching the tissue, that you're actually delivered to that target region. And that's where the OptiShot technology has some interesting aspects. And one of the most interesting aspects, beyond the fact that it's a balloon and a central insulator, is that there's an optical an endoscope, so you can visually look from inside the balloon at which splines are touching in contact and optimize that. So beyond the balloon catheter itself, there's a PF generator. There's a connect that connects all this stuff. This is the heart-like console itself that has a camera, a light source, and there's a pump to inflate the balloon. That's the endoscope itself that you put inside, and then there's fluid inside. And then there's a deflectable sheath, a 12-French deflectable sheath. So if we look at the schematic here, of course, there's a compliant balloon. It's also important, it is compliant. And I'm going to show you some images that shows how compliant it is. If we look at each spline, there are a couple of important points. This orange region, this is the electrode, the ablative part of the electrode. Okay, you can see it extends from the most distal aspect to this one point. There's also a small mini electrode shown here, and that mini electrode is important. Oh, I'm sorry, I said it wrong actually. The electrode is actually the yellow part from here all the way to the major part of this. There's also these mini electrodes that you can record electrograms. So there's 12 splines for ablation, and every other electrode has a mini electrode for recording electrograms. So you can, for example, measure electrograms inside. You can pace from there if you want, et cetera. So if you look at the ablation electrode itself, endoscopically, the white is the tissue that the balloon is pushed up against. The red is the blood, in this case, beyond the balloon, the lumen. You can also see here, for example, this is the back end of the electrode, and this is the ablative electrode right here. And it is important. As far as I know, this is the only technology that provides sort of catheter position constantly during PF energy delivery, because you're looking visually. There is no electrical interference. The energy itself is bipolar, asynchronous delivery of energy, and it alternates between the odd and the even splines. And the idea is to try to achieve circumferential transmural lesions. And so the anticipated lesion depth, by the way, is 5 to 6 millimeters. That's what, based on preclinical studies. So if we look here, this is some preclinical work that Hiroshi Nakagawa did using this sort of a very small type of electrode design. This is what the splines would look like. They put it on the ventricle and delivered lesions. You can see what the lesions look like. And you can see the lesion depths at half dose, single dose, and double dose, between 4 up to 6 millimeters in depth. And again, you see these are 20-day chronic lesions. You can see at half dose, there's some gaps in between. At single dose, it's relatively confluent, but some scalloping. And at double dose, it looks relatively contiguous and not minimal scalloping. This is some preclinical safety work that we did. No phrenic nerve injury, either acutely or chronically. Minimal to no microbubbles, again, because the energy is being directed in the tissue. No PV stenosis, which I think is consistent with all of these PF technologies, and certainly no arrhythmias. And of course, you wouldn't expect to see any such ST elevation because this is being used to isolate pulmonary veins, unless, of course, the patient has a Prinzmetal type syndrome. There's also no esophageal lesions on the preclinical studies, no evidence of endocardial trauma or char or coagulum, and at least preclinically, no peripheral embolization. So none of these adverse safety events with a double dose. What I'm going to show you are some images from the Vision AF study. So this is a single center first-in-human study. So far, I think we've treated, well, actually it says it, we've treated 36 paroxysmal AF patients, and what we're doing is only PV isolation at this point. There are a number of safety assessments, including brain MR imaging, looking for hemolysis with haptoglobin and all the other usual stuff. Of course, looking at microbubbles. All the cases are being performed, including intracardiac echo imaging. Of course, phrenic nerve testing and post-op EGD. Now, we're not doing EGDs on every patient. We did on a number of patients, and then at some point, we stopped. And importantly, the patients are planned for remapping procedures at 90 days, and of course, they'll be followed clinically out to 12 months. So here's again what we're looking at endoscopically. This is the balloon itself, and here you can see the light sources inside. In these patients, after we do the ablation, we do electron anatomical mapping just to define what is the level of isolation, and also because during the remap procedures at 3 months, we want to assess whether or not there's any regression of those lesions. What are some benefits of this very compliant balloon? Well, if you look, for example, you can have unusual anatomy. So, for example, this is a patient that had sort of a roof vein. This is a posterior roof vein. I don't know if you can appreciate that. And here you can actually see this. And what you do is you just position the balloon, inflate it to a point where you're encompassing this so that the ablative electrode, which is all of this, will ablate here as well as here. And I should note, look, this balloon has been used when it was as a laser in over 20,000 patients. So there is a reasonably robust experience with this balloon. The other interesting aspect of the balloon is as you inflate the balloon, it gets bigger. And because it's compliant, it can take these sort of different shapes. And here you can see in the various veins, the left superior, right superior, left inferior, and right inferior vein. Here's an example in a patient. If you look, this is the superior branch of this left common, and this is what you see. And again, when we do the live case later today, you'll appreciate this better. But you can actually see the beating of the heart, and you can see where you have contact. Similarly, this is the inferior branch of this left common. And this is, again, this large left common. You can see the ablation. Here, we did this just as a single big. And this is actually, I think, the case that we showed, that Honza and Toshi showed at the Live Case Summit. And you can see that by inflating this very large, circumferentially they had contact. And here you see the level of isolation. At the top is baseline. At the bottom is the post-ablation map. So last slide, a couple of points. One, this is a very compliant balloon that there's now a lot of clinical experience that it can accommodate a number of different PV anatomies. And it is a PVI tool. I want to be very clear about that. Number two, it's real-time visual guidance without any sort of electrical interference or artifact, et cetera. And I think one of the advantages of visual guidance, of course, is you can ensure contact with the tissue, and you can ensure circumferentiality. You know, one thing you can appreciate from this presentation, but hopefully you'll be able to appreciate from the case, is that when we first position the balloon, you'll see that some areas there are contact and some maybe it's not quite as ideal. So maybe you clock the catheter a little more posteriorly, you may deflect it to get better contact inferiorly. You may decide to make it bigger or smaller. So these are the various sort of maneuvers that you can employ. And again, as you saw, this is a first in human series, and of course we're assessing safety. We're particularly interested in lesion durability. And I think the other thing that we really need, that I think is becoming clearer, is there are many first in human studies where we see pretty good lesion durability. The question is that durability scalable? When you get away from the focus that you have in first in human trials and you get into clinical practice, will you maintain the durability as you go across physician experience and et cetera? And so I think these are the questions that we need to answer for this technology as well as all technologies. So thank you. I don't know if there's any questions at this point, or actually maybe we're saving the questions to the end. I can't remember.
Are there any questions from the auditorium? Vivek, I have one. You probably did all the cases in GA. Is this suitable for conscious sedation, this technology?
Yeah, it's a good question. Actually, we didn't do these under GA. I think maybe the first initial ones we did, I can't remember. But most of these cases we actually do with deep sedation. So, in fact, I think the case this afternoon, where our plan is to do this with deep sedation. So you'll see. And as you'd expect, you'll have some degree of you know, what do you call it, coughing and stuff like that, which is, you know, I think the real problem. Muscular stimulation is not the issue as far as I'm concerned. It's more the coughing and everything else. And if we do have coughing, I think what's going to be interesting is what the impact of the coughing is. You know, when you're using a mapping system, for example, if the patient's coughing, well, that's a bit of a nightmare, right? Because then the map can shift, et cetera. But when you have a balloon, one of the nice things is, even when the patient is coughing during the application, and I should note, the application takes about a minute and a half. Even if they're moving, you have a compliant balloon, the patient coughs, but the balloon moves with the vein. So it actually surprisingly works really well for a workflow that doesn't include GA.
I have one more question. You showed the ablation of left common trunk. What is the maximum dimension of when the balloon is fully inflated?
That's a good question. I think it's 40 millimeters. I'll verify that, and I'll verify that in the afternoon case. One point I do want to make, the bigger the balloon, the less the compliance. Okay, so that's true with everything, right? I mean, when you inflate a lot, then you lose a little bit of the compliance. So in some ways, it's oftentimes better to not inflate so much, let it be compliant, and push forward, and then you get more sort of contact circumferentially with the tissue.
All right.
Hi, Vivek. This is Serge Goveda. I have a question. You are insisting quite a lot on the visualization. You have the experience of all PFA systems. How key for you is the visualization with this balloon? Do you think that this makes a really difference with systems only with a guide wire, for example?
Yeah, it's a great question. Look, I can tell you that when we position the balloon in location, there are times that we vary that positioning based on the what we are looking at. Okay, we can optimize the positioning. Now, you could say, well, aren't there other ways that you could optimize? Let's use just electrical impedance, for example, right? Because these are electrodes. That would be fine, but you can't look at electrical impedance from a very large electrode because it's only part of that electrode that's touching the tissue. And so you're going to get a large contribution of noise. So your sensitivity of looking at contact with pure electrodes is just not that great. Now, on the other hand, if instead of one big electrode, you had a bunch of smaller electrodes, then yeah, you could have very high fidelity of contact and then probably don't need an endoscopic visualization information. And that basically is a strategy that the Cardium Globe uses that Peter talked about earlier. I think in the big picture, I know that the visualization is very useful. In the big picture, with the balloon being as compliant as it is, could you get away from the endoscope altogether? Probably. I don't know. We just have not done that. That has not been the goal at this point. But it's a very good point.
Okay, thank you.
Okay,
another question from the room? No?
I don't think so.
Okay.
I guess Philip Sommer is ready to present. Thank you.
Thank you. So the next speaker, I think, is Philip Sommer.
Yeah.
So Philip Sommer is on site, I think, in the same place.
We can see you, we can't hear you. Please.
So Philip will make a presentation on FORPOS from Boston Scientific, guided by EA mapping. So Philip, please.
Yeah, dear chairpersons, thank you very much, and thanks to the organizers for inviting me. So I'm already on site, since what I'm talking about right now is going to be presented in a couple of minutes in the afternoon session about multiple technologies. And if Vivek just presented some really hot topics and new technologies, FARAPULSE is probably, well, the most established method to do PFA procedures with experience, at least in Europe, for more than 4 years now, and a couple of 100,000 cases being done. But still, if you look at several operators doing those cases, probably hardly any one of them does exactly the same in terms of imaging, in terms of eyes, rotational angiographies, mapping, yes or no. And together with the two colleagues, I think it's Joseph and Tom DePotter doing the next talks, I just briefly going to touch about how helpful and useful it is to use an electroanatomical mapping system in those patients. And I put my hashtag underneath as a subtitle, "Every patient deserves a map," and I want to explain to you in the next couple of minutes why I think this is the case. So generally speaking, why do we do imaging? Why do we do mapping? And I found two answers to that question. Answer number one is I think we want to learn more about our patient, about the patient anatomy, but also about the tissue characteristics of how much do we have to ablate. And I think especially in the times of PFA technologies that we have in our hands, it's kind of seducing to ablate more and more just because we can. And I personally believe that we have to take a couple of steps back and really make sure that what we address and what we ablate really makes sense and enhances the results from a patient's perspective. And I without having data on that, but I truly believe that using a 3D mapping system will improve the quality of our lesions. The big question will be, will we need this improvement, or is a bad lesion with a good PFA device maybe good enough to get the full clinical benefit? This is a couple of examples, and you will be all aware of that from your daily practice and routine. This is a couple of, let's say, anatomical variants like left common ostia, which you see in the bottom row, but also strange anatomies with accessory veins, inferior common os. And I think knowing about these particularities can help tremendously to improve the lesion formation and also the choice of the ideal device, because I truly believe that this one-size-fits-it-all does not really make sense in patients like the one that I've been showing you, because if you have a small device in a large vein, what it's going to do is like ending up more distal than you anticipate and you intend to do, and therefore I think personalizing therapy based on anatomical knowledge is really kind of key. And in the following couple of minutes, I just want to share with you a couple of lessons that we learned in more than 1,000 cases that we did. And we started doing 3D mapping in our first case, and honestly, I never stopped, and I'm going to tell you why. First of all, my motivation was to have a look like, what's the dimension of my PVI? How antral is it? How large is going to be the lesion? Because you're going to see here on that screen some nice work, again, from Vivek's group, showing the different technologies. So this is Penterspline on the upper left. It's an RF lesion set. Upper right, we have a cryo, maybe a little bit more distal, and then we have the laser that still was a laser at that time. Now it's PFA as well. But this is just to show, like, if we say the PVs are isolated, it does not mean it's always at the same level, at the same size, and the same amount of posterior wall tissue actually included in the lesion set. And this is what we learned very initially. You see a large atrium, but also super large lesion in this post-ablation map on the left-hand side. And this patient came back with a flutter, like it has been nicely described also by Julian Schunz and Boris Schmidt group, that inadvertently they created arrhythmogenic substrate. And I think this was addressed during that meeting several times, that we try to avoid these creation of this kind of small rim at the posterior wall. And you see on the right-hand side that we completed the posterior wall in a redo ablation. And that led to a much more restrictive use of the 35 millimeter device with a ferropulse. I, even in large anatomies, usually take the 31, which is like 95% of our cases. Second message is, I think it's, if you go for fluoroscopic guidance, and we're going to see that how Melanie is going to do that in the live case later on, but I think malwiring, so not getting in the optimal branch of a vein, maybe targeting just the superior branch of an inferior vein, or even just a middle branch, can lead to, I call it, forgotten veins. And if you do a careful remap, and if you have maybe CT imaging up front like we have, you will never forget an entire vein. And this is something that we pretty frequently see, especially after cryoablations, that obviously the previous operator was thinking to be in a right inferior, but basically completely missed it. Incomplete isolation, of course, we're going to have that. Like acutely, everything looks isolated, all the signals look abandoned, but still you're going to do it during remapping, find some gaps, which of course you have to readdress, and I'm going to show you the numbers, how often this occurs. Is there evidence for what I'm saying? And I have to admit right now there's hardly any evidence. There's some work from the Basel group of Christian Sticherling, who retrospectively looked at about 200 patients with and without mapping, and they found at the most a trend to better results in terms of permanently isolated veins, but at the price of longer procedures, longer dwell time, and you see the numbers on the right lower. So there was no proof of any significant clinical benefit, especially not from a patient's perspective. And it's highly variable how often 3D mapping is used in daily practice. This is the key studies that have been published so far, like Euphoria, a registry, but also at the Advent, the IDE trial presented by Vivek on ESC 2023, 90% have been mapped. I think in the US, the proportion of map procedures is clearly above 90%, whereas in Europe, in Germany in particular, we are ranging from 10 to 25% right now. We looked at our initial 250 patients, and this is where we acutely and successfully isolated all 4 pulmonary veins in all our patients. And during remapping, we found that this did hold only true in about 228 out of those 251. So in about 10%, and this is completely in line with the data I've shown you here on the right-hand side, incomplete PVI and remapping, when they assessed it, it was in the range of 9%. So the numbers are completely in line. And I think that's an important message. Remapping provides more detailed insights in the quality of your initial lesion set. And interestingly, the right superior was by far the dominant pulmonary vein for reconduction during remapping. And 2 more informations we got from that, and this is already like leading to my final messages. This is that the AF phenotype, so persistent or paroxysmal, did not affect the results. Of course, there's a slight trend towards impaired outcome in persistent, but what really mattered is the question whether there's substrate or no substrate. So low voltage present, then we have a bad situation maybe for the patient, and in a decreased chance of having the patient permanently back in sinus rhythm. And you're going to know that recently for both the NSAID, but also preferably the OPAL or the Rhythmia system, we have the chance to predict the lesion. And that's what we're going to show you later on during the live case. And for me, one of the most important parts of having a 3D mapping system is to optimize the offset of the lesions during the rotation. And I think this is completely underestimated, since we cannot rely on the presence or absence of electrograms, because after the first shot, as you know, everything's gone. But still, I think the lesion quality is associated with how perfect we're going to do the rotation of the device to avoid stacking of the lesions, if you may rotate just from one spline position to the next, but to really get right in the middle of your previous ablation, which will enhance the lesion quality. And as you know, there's the FARAVIEW system, which is basically an integration of magnetic-based information of the plantar spline. There's a sensor at the shaft just underneath the 5 splines. And this allows you to have a visualization of the system and also to have a prediction of where the lesions are going to be created. You see that nicely over here. And I think the most important part is shown here, and that's, again, the rotation. You see on the right-hand side the device that is perfectly rotated in between the previous position. And I think this is something which fluoroscopically, and Melanie just looked into the room here, this is really difficult, I think, to do, to have a perfect alignment of the second positioning of the catheter compared to the first one, if it's just going to be based fluoroscopically. But she's going to show us how to do that later on. And the final point, is it a mapping or a navigation system? So there's a lot of discussions whether FARAVIEW really is considered to be a mapping tool and a mapping system. And I just want to point out that improving signal quality, I think, is key, because we have otherwise really large bipoles if we just look at electrograms from one pole 3 to the other pole 3 of another spline. But you can create bipoles of 3 versus 1 to 4, as shown here. And this is just leading to a massive decrease of the far-field components. On the right-hand side, you have the standard bipole 3 versus 3 with a pretty large far-field component here on the right-hand side. And if you use this Faraline algorithm, so to say, by taking 1 to 4 versus 3, this decreases the far-field component and just leaves you the near-field component of that signal. That really improves the signal quality. And this is just an example. This is an atrial tachycardia that we mapped just with the FARAVIEW. This is signals the more you approach the mitral annulus, and you can still consider pretty fair quality of signals, which can be nicely annotated. And this basically leads to this map that you see on the left-hand side. And with the first energy delivery close to the appendage, basically we could terminate this flutter. And this brings me to an end of my short presentation. I admit 3D mapping prolongs the procedure, no doubt about that. We're talking about maybe plus 10 minutes. But I think that 3D mapping also provides an important insight into individual anatomy and also allows a better success prediction for redo procedures. If you are aware that the atrium has a lot of low voltage, a lot of scarring, you may consider to use another technology maybe in the future. And therefore, I conclude that every patient, even with single shot, deserves a map. And that's what we're going to do at 3 o'clock in the afternoon. So stay tuned, and thanks very much for listening. Thank you.
Thank you very much, Philip. Very nice presentation. Any question from the room? So I have a question, Philip. If I understood well, what you were saying is that if we are logical, we should stop doing PVI without mapping system. Did I get it right or not?
Well, I think we did a couple of PVIs with cryo, for example, and most of those cases were done without mapping. I personally believe that whenever I had my PVI and I come to you and make it happen in your lab, I probably would ask you for a map, because I just wanted to know that you're sure where you are, sure how much you rotate, and can tell me something about my atrium later on. I still hope I have a super healthy left atrium, but I want you to confirm this, and this will be very difficult to confirm by just doing fluoroscopic guided procedures only. So for myself, I would love to have a map, and therefore I think our patients deserve it as well.
And if you have eyes, for example, or CT scan, fusion, or this kind of other tools that gives you the anatomy, do you think that the map is only for PVI? I mean, only for PVI. Do you think that the map is also very important?
I believe yes. Given like the two reasons that I initially shown, I think a CT scan or basically again or eyes, that gives the anatomical information, but the functional information again about how to rotate the catheter, but also how sick the atrium is, this can only be provided by a map, which actually doesn't take long. We don't want to have a super detailed map of 20,000 points like in an Orion case. We will not be able to provide that. But just to have a rough idea if this is a healthy person or an unhealthy, low voltage, scarred left atrium, I think this is a valuable information, especially if it comes to a redo, because otherwise if you do a fluoro-only procedure initially, you have no idea what to expect for the second case. And if I know there's septal scar, for example, I probably would consider another technology which allows me to address septal scar better than probably the ferrous spline catheter.
I got it, Philip. Thank you. Other questions? Yes, there is a question in the room. Is it possible to have a microphone, please? A question for you, Philip.
Thank you very much. I would like to ask you if the usage of pulse field technology changes the perception of blanking period in comparison to RF ablation. Of course, when we also do 3D mapping and avoid all pitfalls which PFA technology brings with it.
That's an excellent question, but maybe it's filling another Congress. Practically speaking, I consider every recurrence 4 weeks after my PFA procedure as a failure and would reconsider a reablation. And that is much earlier than we used to do with RF, because I personally believe that these healing processes, this inflammation, this edema, all the stuff that we think to know about RF ablations do no longer hold true for PFA. And in my clinical observations, I would say that within the first 4 weeks, we can have recurrences that will disappear, but everything that will show up after 4 weeks will still persist and probably requires another intervention if it's antiarrhythmics or reablation. But like internally, we consider the blanking period after PFA only 4 weeks.
Philip, Danny speaking. I have the last question maybe. I like the idea of connecting 1 to 4 electrodes against 3, just to eliminate the far field component. Do you think it should be like standard connection from the very beginning for all patients, or not?
Well, yeah, far field is always annoying and can be misleading, especially if you have atrial tachycardias. Left superior PV, for example, you're always going to grab a signal from the appendage. So it can be misleading and people can be confused. So the less far field you have, the better it is. And why not making it a default setting in all the labs starting with FARAVIEW? I think it can just improve things. It does not eliminate far field, of course, but at least it makes the signal quality better.
Yeah, thank you.
Okay, thank you very much, Philippe. This is my pleasure now to present our host, Professor Joseph Kostner from ICEM, Prague. And Joseph will make a presentation about FARAPulse Boston Scientific guided by ICE. Joseph, please.
Thank you. Thank you, Serge. So, as you heard, I will talk about intracardiac echo, why we need intracardiac echo and not maybe so much mapping system. Philip nicely showed that you have different shapes of atria. Also showed nicely that from a FARA-wave catheter you can get very nice signals and you can do entrainment. So I don't need mapping system to see if there is low voltage, if there are fragmented potentials. I can see it from my recordings. I don't need a mapping system necessarily for this, but I need to know how is the atrium conformed, what are the numbers of pulmonary veins, and what is the size of pulmonary veins. Why is ICE useful for AF ablation in general? That was nicely explained yesterday by Fermin Garcia, and so I don't need to go through these details. But again, I will remind you that pulmonary veins are different. They have different size, different shape. They could be there could be a long trunk, a big trunk on left side. So these were studies we did 20 years ago, or even more than 20 years ago. We had already at that time 3D reconstruction of left atrium from MRI, which was done by one of our engineers. And we published some data about the size of pulmonary veins and about their shapes, which is very useful. So for instance, the size is on average 2 centimeters. Even a common trunk can have like 33 millimeters. So that's the reason, for instance, why I use just a smaller flower, not 35 millimeter, because that's too big, and you can do ablation with a smaller one practically in all cases. I have always the discussion with Boris Schmidt and others about this need for intracardiac echo, and he claims that intracardiac echo is 2D method similar like X-ray. I cannot agree with that, because of course it's principally 2D, but you can have with intracardiac echo, you can rotate, so you can get additional views, and you can also change projection. So you can go, for instance, to right ventricle, and you can see third dimension. I will show you why. So this is from Boris's study, showing that you can display pulmonary veins, but you don't see the third dimension. And that's maybe explanation why they see in some of these regions gaps and reconductions. Because if you look, for instance, for a study which was done in Homolka with Vivek Reddy and Peter Neugil, they achieved practically 100% durability when they used intracardiac echo and guided the procedure with the most, let's say, tuned pulse configuration during the early studies with FARAPulse technology. And of course, as I say, you don't need mapping system to know in which vein you are, but this is not the best view to display. And most of the left veins come to the atria as a common short trunk, and you can see this ridge between appendage, which is here, and the left vein here. So you can see it clearly when you go to RVOT with your ICE catheter, and this place could be very narrow, could be very broad, appendage has different shape, so you know exactly the precise anatomy. And so this view, in my opinion, is very important for ablation with any tool, which even if you do point-by-point ablation, because then you can precisely be on this part of the ridge. This is an example. If you put wire and you just go over wire tends to hook on this ridge. If it's floppy, it can even displace it. And then if you put a device to this area, this can mislead you, and you may not completely cover the whole antrum of the vein. So here is example that you can do flower, you can push it over the wire until it stops, and you see the tool is here touching anterior wall and it's not touching posterior wall. There are no electrodes on this area, which has to be really covered properly. So if you rotate posterior, you can optimize the position of this flower. And there is no way to recognize on fluoro. There is not much difference between these two, but there is a big difference here and here. So that's very important to realize. This is another example. You are sitting on this ridge if you are just pushing over wire, and the extent of posterior torque is difficult to estimate unless you see it, because sometimes if you rotate too much, it prolapses inside and you are ablating just posterior wall. So it's very difficult to, even with experience, to know exactly where you are. The same is inferior vein, for instance, could be sometimes problem because it could be too small, too big. So again, you can position your tool precisely. If you want to do anterior line, you can again position your tool close to the mitral valve, below the appendage, and you can have a very nice anterior block. If you have a common osteum, again, you can optimize the size of the device, or you can do lower and upper movement of this device to cover the whole circumference of this bigger vein. But as I said, most of these veins are about 3 centimeters big, even if there is a common osteum. And there's tremendous variabilities. You see in a young patient, because of a very perpendicular position of the heart, you may not have even in the same plane appendage and left vein, left superior vein. So you have to rotate and to cover properly this area. And this is a very thick ridge, so sometimes you can really stay on the ridge very nicely. It does not displace. The same right inferior vein could be very big, so you can again optimize the position. You can optimize the position of the basket in this vein to cover really the whole antrum. Fermin yesterday showed you that you can do, you can go to left atrium. Most of the time we don't need to go to left atrium, but you can do it like he showed here, that you do, you have cartosound and you can enter close to wire. But as Peter Nožil mentioned today, if you have wire retained, you do transeptal puncture, retain wire, then you go with eyes close to the wire and you can enter the left atrium and you can see directly pulmonary veins, especially right-sided veins, which are sometimes a problem to be seen. It's like you can see here, it's a right inferior pulmonary vein. And you can measure, you can assess also thickness of myocardia. I don't know, Philip mentioned that from electroanatomical map you can assess the thickness. I've never seen assessment of thickness from electroanatomical map, but I can measure, I can see the thickness of the tissue here on online imaging, which is the only online imaging which is practical for use in electrophysiology laboratories, echocardiography. See? Different shapes, different sizes, different thickness of myocardium. We do often posterior wall isolation. We can do CTI We can do also mitral isthmus. So this is a view of mitral isthmus. So you can optimize the position of your catheter on a mitral isthmus. And in this case, we change perimitral flutter to typical flutter after application. And then you can go to right atrium. You can do flutter ablation. This is one technique using a basket, but you can do also flower. And we are doing a study now comparing these two strategies, which one is more efficacious and safer. And then you can come back and check mitral isthmus block pacing from the appendage, and you see that there is a block. There is also safety aspect of using intracardiac echo. This is from first cases by Farapulse. And you see that in some centers they had tamponade, 2 strokes, although they did very few cases. And they had sometimes 3 cardiac tamponades in relatively few cases. And the explanation was that this was because of straight wire. I don't buy it, because unless you have intracardiac echo on site and you see separation when it happens, you can never reconstruct what was the cause, of course, unless you have sheaths through the wall. But otherwise, there is no way to know exactly why it happened and where it happened. So this is safety aspect that you can really recognize effusion at the beginning, and then you can stop anticoagulation, revert anticoagulation, you can do drainage, and you can seal the hole, and that's why you don't need to go to surgery. I don't remember when we needed in some tamponade going to surgery. You can also assist the transeptal puncture, and you can see smoke-like echoes, like a high risk for thrombus formation. You can see bubbles, you can see thrombi on site, so very important for safety. If you have ice, you have to use ice. And this study from Italy tried to compare 2 groups of patients, one done by ice and one without ice. But if you look at these pictures, they only use the ice to see if they are in inferior vein or superior vein. And they had even a higher fluoroscopy time in ice group, which I cannot understand. So if you have ice, you have to use ice properly, because otherwise there is no point to spend money for ice. And this is from Fermin's presentation, that really ice has a lot of advantages compared to other imaging tools. And compared to 3D map, it is real time anatomy and not a virtual anatomy. So you can see today a case of ice-guided ablation with Farapulse device without mapping, without need for additional imaging like CT scan beforehand. So thank you very much for your attention.
Thank you very much, Joseph. Very nice talk, very nice images. Maybe a few questions from the room, the audience? I have a question for you, Joseph. It's the same question I asked to Philip. When you use ice, do you think that it's also useful to do a 3D map? Or for you, it's okay with ice and nothing else?
Most of cases we do is without mapping.
Okay. So you can replace map and ice. Okay. Interesting.
No, well, you cannot replace for quality of imaging or anatomical information. That's obviously better from ice.
Yes, of course.
But to see if there is a low voltage area or fragmented potentials or whatever, some abnormality, you don't need a 3D map. You don't need colors to see this. The same with in some areas where you do VT ablation. You cannot just rely on colors, because you can have a subendocardial scar, you have high voltage, and still there is a scar. So unless you pace, unless you do some functional pacing, you cannot see that there is a scar, unless you see it also on ice, which is the usual combination. So you see thinning of the wall, or maybe subendocardial scar, then you see fragmented signals, or maybe just split signals, but there might be very high voltage still, because you have the voltage comes from the other layers of the wall. So
another question. Are you doing sometimes PV isolation without ice, or it's
No,
100%?
we use 100%.
100%. So maybe this is the reason why, as you say, if you use it, you have to use it well. And if you do it a lot, so you do it well. So this is a good point. Questions? Other questions? Dan?
No, thank you.
No question for your colleague?
I know everything.
I'm not there to have questions.
Okay, so thanks again, Joseph. Next speaker, it's a pleasure also to present our next speaker, who is Tom de Potter from Belgium, Aalst, who will make a presentation about Ferropulse Boston Scientific guided by rotational angiography. So Tom,
disable the pointer. No, I don't want the laser.
thank you.
Okay.
And I want the screen.
And don't be shy. Eh? You can
I don't want double screen.
You can ask questions, you can exchange, give your inputs. We need interaction also, it's important.
Thank you.
So Tom, please.
Thank you very much, Serge, Dan, dear friends. Thanks a lot for the invitation to present on our experience using 3D fluoroscopy integration for single-shot PV isolation. These are my disclosures for this particular presentation, and this is the other disclosure I have. It's not my goal to convince you of anything today. I don't want to tell you you have to do anything, especially if you are using ablation catheters that have native integration into some sort of 3D mapping system, such as, for example, the catheters integrated in the Carto system. Of course, it makes a lot of sense to use those. However, if you are using catheters that do not have such native integration, I think there's a lot to be said for the approach I want to show you, for the approach which provides imaging and which provides 3D modeling without having to use an actual 3D mapping system. The reason we need to do this, the reason we started doing this 15 years ago, is of course that, as we've seen amongst others in the previous presentation, is that the geometry, the anatomy of the left atrium is complicated, is difficult to understand on X-ray alone. That's why 3D mapping systems were invented in the first place, and especially in the era of point-by-point ablation, it's quite challenging to make sure you make all these lesions accurately. And so enter 3D rotation angiography. What is 3D rotation angiography? It is an approach which you could call a pseudo-CT. It is using your C-arm and your monoplane X-ray system to recreate a CT model on the table of your patient. The benefit compared to CT is that you can do it on the spot, of course. It's as it happens as you are doing the case. You can integrate it with the 3D mapping systems. You can merge it. And particularly for this presentation, the big benefit compared to CT is that you can automatically also integrate it in your X-ray system, because the X-ray system is doing the acquisition. It knows perfectly well where to place it. This is the system we use. You can use it's available on all the commercial X-ray systems. You need to think a little bit about the detector you want to use, but I strongly believe that a 20 by 20 centimeter detector is ideal for the purpose of mapping the left atrium. If you use bigger detectors, you will tremendously increase your exposure, your X-ray exposure, and so you will need to collimate anyway, and you will have issues rotating around the patient. And the reason I bring this up is because one of the responses you usually get when you talk about rotation angio is it's a lot of radiation exposure to the patient. And yes, but you can do something about that. You can do something about reducing radiation, and you can do something beyond blaming our poor patient, because this is the typical response. Of course, you say, oh, it's a patient's fault, bigger patient, more exposure time, more radiation, and this is true, of course. If you have patients with higher BMI, you will increase quite linearly their radiation exposure. But what we realized when we started doing 3D angio is that it makes no point to try and get really good quality images in these obese patients. And without going into too much detail, the reason behind this is that the X-ray systems we have are simply not capable of providing enough energy to go through the skin and the soft tissue of these obese patients. And this is data from our detectors. Again, don't worry about the numbers, but what we realized is that the detector is shooting your patient full of photons and you are not getting a nice image as a result. So what we did, instead of trying to optimize our images, we told GE, forget about this and give us lower quality 3D angio. And this is precisely what you can do. And you can dramatically reduce your patient exposure by accepting a very small, I would argue, almost invisible reduction in image quality. Again, for the purpose of understanding where the veins are, the quality is quite sufficient, as you will see. And the net result of this is, to put it in perspective for you, is that our patient exposure for a 3D angio is below 1 millisievert. It is on average 0.7 millisievert. To put that in comparison, some more numbers for you. If you fly 5 times to the US back and forth, so 10 long-haul flights, you will have accumulated the same radiation exposure as that patient undergoing 3D angio. The operator, of course, receives 0. The operator is not in the room as you acquire the image. And the final thing I want to say about this, what is important to realize, is that the image does not have to look pretty. The image can look pretty if you present somewhere, but in real life, it's perfectly okay if the image is not as great. And this is sometimes the image you get, posterior view of the left atrium. And once you've started getting used to these images, you understand that it's perfectly doable. You don't need to repeat this. You don't need to increase the X-ray dose. You can perfectly see where the veins are. And where the veins are is what you want to know to do the ablation. So the process we developed is a process we call the conveyor belt, which is a process which our AFib patients, our AFib population undergoes. And specifically for the 3D angio, this is the general workflow. So we acquire the images. This does not take a lot of time. If you do it in every case, you can become quite proficient at it. The average time for acquiring the 3D image in our lab is 5 minutes. Then we reconstruct, we segment. If you do this manually, you need another 5 minutes. As I'll show you in the video, in our lab, it's automated now. It's about 30 seconds. And then initially, as I said 15 years ago, we used this actually to enhance our CARTO workflow because we did not want to make electroanatomical maps the whole time. And we did not want to do CT scans either because it posed logistical challenges for us. So we used this as a replacement for CT. But of course, you can also use it to overlay on the X-ray. If you do point-by-point ablation, it's not particularly useful. I'm sure you can imagine that it's quite hard to use, even if you have such a nice 3D model, to use point-by-point ablation and achieve isolation. But once you start using single-shot devices, this story becomes completely different. If you start using single-shot devices, you can imagine such a 3D map will be very helpful to help you understand where you need to go. And this is an example of a case we recorded to illustrate you a little bit how this works in practice, how the concept goes. So our workflow in our PV isolation cases is always the same. It's a minimalistic workflow. We try to do as little access as we need. So we do a single transeptal puncture. We do double venous access because we need a pacing wire. The pacing wire you see there on the screen. So we do single transeptal TEE guided. And we have a pacing wire because when we put the pigtail is now in the heart, we will do fast pacing to keep the contrast in the atrium. So here we're doing a test injection to center the pigtail. And now we're doing rapid pacing in the ventricle, and the tube is going to rotate around our patient. And this is the actual acquisition. And so you can see that the contrast, of course, is nicely staying in the left atrium. Now this data, this image, goes to a segmentation platform. So this is something we developed in-house. This is an AI-driven pipeline that is completely automated. I showed you in the beginning, if you do this manually, you can do it in 5 minutes easily, although you do need a little bit of training. You need a trained operator. But what we have done is take the human equation completely out of this. And so in the time I'm telling you this, our machine learning platform makes this, which is a black and white, yes or no, you are in the atrium or you are not in the atrium model. And this is automatically transported back into the imaging system. And the result then you get is what you will see in a second, is that the 3D model now is integrated and ready for use in the fluoroscopy system. So here's the 3D model that was generated. You can look at it, you can evaluate it, see if you miss anything, but typically we don't. So you can see again 4 veins. You can see at the roof it's a little bit cut off, but it's not a particular major concern for the purpose of our procedure. And now we have the 3D model. And as I mentioned, one of the nice benefits of this approach is it is automatically where it's supposed to be, of course. It is automatically on the X-ray where it is supposed to be because the X-ray system made the image. It's perfectly aware of the coordinates. This also means that if you manipulate the system, if, for example, you rotate the X-ray system, the 3D model will move with you. Basically, what you have is you can think of it as a PV angio in every orientation you can choose. So instead of making PV angios in, for example, RAO, LAO, you now have PV angios in every angulation that the X-ray system can provide, which at the end of the day is the 3D model you are seeing. And so if you move the table, you change the angulation, the model moves with you. And so once we have this, we're now ready to do our ablation. And so what we typically do is we don't use the 3D model, we use the outline, as you see it here. The Farapulse sheet is ready, and you can see we can quite easily, of course, point the sheet to the vein where we want to go. The wire goes in the vein, and there is no discussion where everything is. If you have done 500 Farapulse cases, I agree there is no discussion where the wire is anyway. If it is your first case, if you are an inexperienced operator, if you are not particularly comfortable navigating catheters and wires in the left atrium, I would argue a map of the left atrium is highly valuable. I agree with Philip, every patient deserves a map, but I would argue that the voltage information for the purpose of PV isolation is far less important than the navigational information that this sort of approach provides. And what you see here is an example of that. I'm directly putting my sheet in the vein. I would never try or dare this without good confidence of knowing where everything is. But the system shows me where the ostium is. I can put the sheet there and advance the wire. And I don't have to worry that perhaps with my sheet, which is quite a brutal sheet, of course, if you use the sheet unprotected and you push against the posterior wall or you push in the appendage, you will go through. If, on the other hand, here I rotate my system and I can perfectly see where the appendage is, there is 0% chance that I might accidentally push it in the appendage. It's impossible. I can see where it is. The system tells me this is where the appendage is. Don't put the sheet there. No, instead put the sheet in the vein. So I'm not going to show you the entire case. Of course, it's a Farapulse case. I'm sure you can imagine what will happen. We will deliver PFA pulses in the veins, and they will be isolated. But I do want to highlight a few interesting aspects. One of the things Philip also mentioned is this overlap. And again, here, just look at how intuitive it is. We rotate the model. We're now in RAO. Our catheter is in the LIPV. We can deliver, and we can rotate the catheter, and we can visually quite easily confirm and confirm for ourselves that we achieve the required overlap to make efficient ablations. I would argue, and I hope you agree with me, that it's all quite intuitive. Moving to the right side, similar ease of use. Again, the sheet unprotected. Here, you can see it's in the RIPV, no discussion. I know it's in the RIPV, so I'm not even going to put the wire. I'm going to open the curve and go a bit closer to the RSPV, and now I can try and engage. And here I can see that now probably I am in the RSPV, but I will rotate the system again to confirm, because the RSPV, as you see, is quite anterior in this example. So simply we rotate the system a little bit, try and understand where the wire is. Here it's clear now, the wire is indeed in the superior vein, so we can go on with ablation. Here again is showing the assessment of overlap in the right superior pulmonary veins. Now we're looking from the other view, of course, we're using the LAO view to understand if we generate the necessary overlap in our rotation. And finally, we'll move the catheter to the inferior vein to the RIPV. Again, direct intubation of the RIPV, no need for wiring anything. I can go there, it's there, I know it's going to be there, and I can advance the wire. And I would argue that, again, yes, a 3D model, I hesitate to say 3D map, a 3D model of the left atrium is highly valuable for doing this type of procedure. But I would also argue that if you have to discover this 3D model with a 3D mapping system, a small branch like this one, you're only going to see it and find it if you went there with your catheter. If the tool you are using to map is particularly bulky, most likely you will not see it, you will not identify it. You will never be able, for example, to understand that it's a nice branch to put a wire in. If you have a complete 3D model, like a CT scan would give you, or like a 3D angio would give you, with the benefit of automatic integration in your X-ray system, and the benefit of being able to do it on the spot whenever you want, I think this is a superior approach in terms of navigational capability. Yes, you do not see functional information, but like Professor Kautzner said, you can see functional information just fine by moving your catheter around in the left atrium and looking at what the signals tell you. So that is a bit to explain you the concept. We'll show you in the live case, of course, later this afternoon, but I think for the approach itself, my take-home messages are, there's no doubt, of course, if you've been to this meeting even in the past 5 years, you should already have picked up that PFA is truly revolutionizing PV isolation. The workflows we have developed have become extremely standardized with a strong focus on safety. The revolution is mainly driven by technological advances, and I believe for all of these single-shot devices, especially the ones that do not have native integration with 3D mapping, understanding where you are, understanding the anatomy is crucial. 3D rotation angiography allows near real-time model creation, automatic integration with X-ray. There is no change. For example, if you do CT, you can have changes in fluid status because you did it 2 weeks ago. You are independent of the radiology department, and without denying it, of course, the main driver for us to do this was economical. If you live in the US, you get paid to do 3D mapping. If you live in the EU, you lose money if you do mapping. If you take a mapping catheter for a non-mapping enabled PFA device, you will lose money. This is the reality we live in, and 3D rotation angiography, on the other hand, has an almost zero additional cost per case. The cost is the cost of the pigtail catheter and the contrast. Having said that, I don't want to convince you that this is the only way forward for PV isolation. I think any sort of imaging has been the driver of innovation, at least in our lab, and this can perfectly well be 3D electroanatomical mapping. It can be 3D angio, it can be integration of these systems. I fully agree that echo-guided everything is the way forward. Ideally, ICE echo-guided, but again, there is an economical argument to be made. And I think we're in the era now of moving a little bit beyond efficacy and trying to achieve workflows that through this imaging help us to reduce complication rates, hopefully to the point where we can say we have eliminated every avoidable complication. Thank you very much for listening.
Thank you very much, Tom. A great talk. So you are doing 100% of your PVI cases with rotational?
No, I am doing 100% of my Farapulse cases with rotation angiography. Okay. Like I said, if, for example, if I'm doing a Varipulse case, of course I will use that. If we have native integrated catheters, we will use those. You could even argue that for Varipulse, it's nice to have, like you would have a CT model, but the added value for me personally is not big enough to do it there. It's nice to have, but it's not essential. For Farapulse cases, I think the added value is massive.
Okay, makes sense. Thank you. Dan, questions? The audience?
Maybe a short question. Are there some patients in whom this technology fails at the end because maybe it of course requires some learning curve for staff, injection, pacing, everything. Are there any cases in whom the image is not optimum or even like misleading?
Image is non-optimal for sure, and I showed you, and we grade. Actually, we stopped grading our images. We have almost 10,000 images, but we used to grade them. And yes, suboptimal quality, yes. Quality so bad that you cannot do the case is exceptionally rare. It's 1 in 1,000, and then you redo it. I do have to point out there is one important element that I think is needed to have a nice workflow, and that is GA. It is doable without GA, but you will not have 99.9% success rate. You will fail more often because maybe the patient, they need to hold their breath. You need to pace them rapidly. They're awake, they lose consciousness, they forget to hold their breath, and it can get a little bit messy. It's doable without GA, but it's certainly not 99.9% reproducible without GA.
Any limitation in patients with renal failure?
We normally use 100 cc's contrast unless the GFR is below 30, then we dilute 50-50. We have not had a single case of acute renal failure.
Okay, thanks a lot. If there are no further questions from the audience. So we'll move to the next speaker.
Yeah.
Thank you. Who is me?
It's Serge Boveda of Toulouse, France, and we will leave the Farapulse technology and continue with cryo, but not for paroxysmal, for persistent. Please.
Yes, thank you very much, Dan. Okay, thanks a lot. So when I saw the topic, I thought it was a mistake to speak about cryo, but now I understand why. I am treating your PFA addiction because you have already too many presentations on PFA, so this one will be on cryo. So cryo, even if we are not using as much as we were using during the previous years, we are still using, and for a few reasons I would like to convince you. So you all know about the results of the champion single shot that has been recently in the New England Journal of Medicine, and it seems that, okay, cryo is dead. Is it really dead? I think that first, this is for only PVI. We are not speaking about the persistent AFib. And second, even if there is a trend for superiority with PFA, this trial was not designed for superiority with only 200 patients. So I think that for the moment, cryo is not dead. And by the way, I think that cryo has still very good advantages. And the first one is that you can see the PV potentials very well, which is not the case with a lot of tools that we have today. And if you are looking a little bit, if you are rotating a little bit, the mapping catheter, you can see that here, for example, you have no PV potential in this vein, but you see that the mapping catheter is too far. You are coming back to the balloon, and with 1 second, you can see here that you have a very nice PV potential. Same in this vein, you have a nice, sharp PV potential. And why is it useful? This is useful because if you don't have a 3D mapping system, if you are working with only the mapping catheter, you can have a very good idea about the quality of your PV isolation. If you have a short PV isolation in less than 1 minute, that you can see here, you have your PV potential that you have a prolongation, and here a disappearing. Between this bit and this bit, you have an entrance block. If you have this in 30 seconds, for example, that means that you have a very good PV isolation with a very good quality of your lesion. And the job is done for this vein. And this is very simple as now you can do it also for the exit conduction. You can do exactly the same. You can place the mapping catheter at the entrance of the vein, and you can pace with for example here, 3-4, you pace slightly faster than the sinus rhythm, and you can see that you modify the P wave here because you are now, here it's a fusion, you are not capturing the P wave, but here you are capturing the P wave. And while you pace, you freeze at the same time. And again, you're following the tracings, and you can see that here there is a very slight prolongation of the distance between the spike and the P wave, And here, you lose the capture. And you can see, in the same way, that between this spike and this spike here, you have an exit block. If you have this in less than 1 minute, this is again a very good indication of very good quality of your PV isolation. So this is interesting, and this is something that you cannot see with PFA, because you all know, and you have seen this morning, that when you are doing only the first application of PFA, everything disappears. So when I did my first case of PFA in May 2021, I did the first application, I looked to my nurse, to my colleague, to my fellow, and I say, is it done? One application, it's done. No, it is not done, because you don't know exactly what you did. This is something that you know exactly with cryo. You know exactly what you are doing. But this is not the only thing. The other thing that is interesting with cryo is this trial that we did in France many years ago. We took centers that were doing both RF, the point-by-point 3D, RF, the typical one, and in the same center, they did also cryo, PV isolation. And we took, on purpose, centers having very different volumes. Low volume, less than 100 AFib every year, between 100 and 500, and more than 500. And we looked about the results during the follow-up. Look, on the left, what is this? This is cryo. After 2 years, you can see that all the centers, high volume and low volume centers, have the same success rate at 2 years. On the right, same centers, same operators, same teams at least. And you can see that this is completely different. Actually, the only center that has the same success rate with cryo and RF is the gray one, which is the highest volume center that we have in this trial. This center was in the Fire and Ice trial, so very high volume center. And differently to what you have in the Fire and Ice trial, where you see, you know that in Fire and Ice, RF and cryo was equal at the same success rate during follow-up. If you take real life, what is happening in France, for example, as global, or in Czech Republic, or in Spain, or in Italy as global, it's not true. Cryo does better than RF, because you are mixing together high volume centers and low volume centers. So if you look at it globally, the only way that you can say cryo is equal to RF is in high expert, high volume centers. This is true, but not in real life, in fact. The other beauty with cryo is that it's big. It's a big balloon. And what is it good? It is good because you can see that here you have the image of the vein and you have the image of the balloon. And you see that the balloon is twice or maybe even 3 times the dimension of the vein. What does it mean? It means that when you are ablating with a cryo balloon, you are not only ablating the PV ostium, you are not only doing PV isolation, but you are doing more than PV isolation. You are doing substrate, you are doing sometimes, if it's not too large, if it's not a too large left atrium, you can also do the ridge between the 2 veins, the intervein. You can do many things with a cryo balloon only on the veins. And this is an image that we did in a patient that we did with my friend Mario Oliveira in Lisbon. You can see here, this is an RF procedure, a recurrence of patient that we did with cryo, and you see that with cryo, 28 millimeter balloon, 1 application for all veins, and you see that the map after the ablation on the posterior wall is 2/3 of fibrotic tissue, treated tissue, and only a small corridor in the middle for still alive tissue. And this is why we did in 2018 a trial with German centers and 1 center from Athens and French centers, obviously, in which we looked about the success rate for short persistent AFib. Short persistent, that meant at that time less than 1 year AFib duration. And in these patients, you see that only with 1 operation, one procedure, after 1 year, we had a 60% success rate It was a very good follow-up with event recorders, etc. And we had 60% success rate at 1 year. 60% is not very good, to be honest with you. We are not very proud about this result. However, it's as good as what you have in STAR-F2, for example, with one operation of less than 1 hour. Only veins, nothing else. But obviously, we need something else. And this is what we thought about. What can we provide with a cryo balloon that could be more than the veins? And this image is something that I want to share with you. It's interesting. This is the way that we are doing in my center, PV AFib patients, all AFib patients. We are using CT integration with the fluoro. So when I was listening to my friend Tom de Potter, I thought that this is exactly what we are doing in my center. However, we are not doing rotational angiography, we are doing CT scan, and we are making the fusion of the CT. It takes only 2 minutes. It's not me, it's the nurse that is doing. It's much better than me. And she's doing the integration of the image from the CT scan in the fluoro system. And you see here the trachea has been reconstructed to have a landmark here to fix the image on the trachea. And obviously, this rotates in 3D dimension. And this is interesting not only for the PV anatomy, which I agree, and I agree with all of you. And in fact, when I think to myself, AFib ablation is like taking a car and going to vacation. You like to use Google Map, you like to use Waze, you like to use plans. You have your navigation system. In AFib ablation, we all have our navigation system. You use eyes, Joseph. Tom, you use rotational. I use CT integration. Philip is using 3D. We all have our favorite system. And I believe that, in fact, this means something that is important, is that we need something to help us. And I agree with all of you, and I really like the presentation that we had this morning, is that it makes sense to have something that will help us to understand a little bit better what is the anatomy. Because it's true that if you don't have the image of the rotational or here with the CT, you can miss a vein. This happens. This is possible to miss a vein. If you have the image, it's a clear, simple image that you have in your system in front of you, you know that you will go to every vein that you see. And this is, I believe, very important. But it's not only important for the veins. It's also important if you want to go out of the veins. Because here, for example, you can see very clearly the roof. And it can help to guide the balloon all along this roof with the positions of the balloon, one here, one here, one here, one here. Generally, it's 4 or 5 applications of cryo balloon on the roof. And this is very useful to have a navigation image or system, what you want. But in fact, I think that this is very important. And the first paper that made me think about that was the paper by Malte Kunis, German paper, that did something that I think is very interesting and very smart. We didn't spoke too much about this very nice idea. They took 200 patients that they divided in 2 groups, one RF group, one cryo group. And in every group, 50% of the patients had only PV isolation and 50% had PV isolation plus roof. One with a RF and the others with a cryo. And okay, they did a roof line with the balloon. You can see here what I have in my lab with a CT scan. They have here, they draw a line, and they did 1 application, 2 application, 3 application, overlapping the balloons, one beside the other one, and they followed the patient during 3 years. And if they took all the patients together, you can see that there is no difference, no significant difference with cryo and RF. So you say, okay, we all know that, it's not new. But if you go more in deep, you can see that if you take only the group with a roof line, and you compare RF and cryo, look, the cryo is doing much better than RF. What does it mean? That means that probably the line with a cryo balloon is more efficient than the line with RF. This is not proven, but this is one indication in this direction. And it makes sense because a cryo line with a cryo balloon, when you make a map after, you can see that this is not a line. It's a highway that you have in the left atrium. You have a so big tool that it's difficult to leave a gap on the roof. And in addition, the roof is generally not very long. So with 4 or 5 applications again, you can have a very efficient line on the roof. Another thing that you can do with a cryo balloon is the left appendage. Okay, we are not doing anymore, but you can see here, for example, you have an occlusion of the appendage. You can see the contrast that is staying a little bit here at the proximal part of the appendage, and you can do a left appendage isolation quite easily with a cryo balloon. A few years ago, we spoke with my friend Hikmet Yorgun from Ankara, and he asked me to put our patients together that we did with a left appendage isolation. So it was only patients having PV isolation and left appendage. No roof, only PV isolation and left appendage. Most of my patients had a roof. However, I had many patients that had only left appendage isolation and the PV. And we looked for a long follow-up, 5 years of follow-up. And you can see that the success rate, so sinus rhythm at 5 years, it was retrospective, so it's not, honestly, it's not a very clean trial. It's a retrospective trial. However, the success rate at 5 years is not bad. It's 68% of sinus rhythm at 5 years, which is, in my opinion, something that is completely acceptable. However, look on the right. The problem is here, stroke. Stroke, you have 7% at 5 years of stroke. And this is, for me, the big issue with this problem of the left appendage without occluder. And this is something that I want to insist on. Because when we looked to all patients that had a stroke, in 80% of the cases, there were patients that stopped anticoagulation without a protection with an occluder. And you can see that this is a very, in my opinion, a very big issue. You can see that you have a total of 5.6 plus 1, it's nearly 7% of stroke risk after 5 years, while you have a quite acceptable success rate, I believe. And this is, again, a procedure of 1 hour, 62 minutes, 1 hour procedure with a fluoro time of 7 minutes, which is also, again, acceptable. And then I will finish with the posterior wall for persistent AFib. Honestly, I tried a few weeks, a few months maybe, and I abandoned. Why? Because roof is okay, roof is not a problem, but the posterior line with a cryo balloon, I can tell you that it's really difficult to do. And when you are doing a map, in most of the cases that I did myself, probably because I am not very good, I had a gap on the posterior line. And if you're looking to this paper from Arash Ariana, you can see that, in fact, himself was saying that in 30% of the patients, he had to do RF applications in the posterior line, in the lower part of the posterior wall. And this is exactly what we had. We had in most of patients that I did in my lab, and I did a map, I had this kind of image with a gap here in the middle of the posterior line. So here you need to add RF, and in my opinion, this was too complicated to do cryo plus RF with a 3D, etc., for me. So I stopped doing this. However, in this paper of Ariana, you have a very good success rate at 1 year. You have 80% of sinus rhythm compared with 65% more or less with PV isolation only of recurrence of AFib and all atrial arrhythmias. So my take home here is cryoballoon ablation is effective and safe. We all know that. for the first ablation procedure of a persistent AFib. I would add here short persistent AFib. I think that patients having a large left atrium are not good indication for this approach. This is my belief. They provide high rate of durable PVI with wide antral lesions that gives you a success rate at 1 year of about 60%, something maybe a little bit more. It's fast, with low fluoro times. You can add, if you want to improve your success rate at 1 year, a roofline, which is very efficient, I believe. I did a lot, and we have good examples about that. It works well. We abandoned to do the left appendage for the reason that I told you, for the risk of stroke. I think that this is an important issue. And we stopped also doing the posterior wall. So, thank you very much.
Thank you. Are there any questions from the audience?
Yes. Yes, Claudio.
Yes, Serge. I think that we have been sharing a lot about cryo, and I think that probably even though the PFA probably will become the major energy source that will be used in the future. I think that cryo is still there, and you have presented data that the clinical outcome is still quite high, not much different from the pulse field ablation as well. I want to just add something because as to be published in a Circulation Arrhythmia, our paper considering the follow-up after 10 years or more than 1,300 patients treated with cryo in a multicenter study in our country, in Italy. And we have almost 60% of patients still in a standard rhythm. And will be published just in a few weeks. So I think that is, another, value of cryo. And I think that at least, for the time being, not every EP lab has the opportunity to use the PFA. So I think even in other countries, for example, in Asia, there's already have some issue to have new technologies, and cryo is still there and very active. So I think that probably we need just to have a small room for cryo as well, just in case we need it.
I fully agree with you, Claudio, and I thank you to say that. I am in the same line, and as we say in France, we don't have to throw the baby with the water of the bath. We need to think about the fact that cryo is something that has proven that it works. And the data that you're providing here, and thank you for providing this data, it goes in the same direction. This is also our observation. It's very efficient for PV isolation, it's very reliable, and even more, and I think that this is important, is something that you can diffuse very easily to other centers, and it's very reproducible. And I think that this is something that we shouldn't forget, because it's true that PFA, it's a kind of, let's say, it's a new generation cryo, because it's something that is a single shot, it goes in the same direction. However, my fear here is that it's very easy to do, you can go very fast. But if you are not very experienced, sometimes you may leave gaps, and sometimes I think that you don't have enough feedback to understand if what you did to the veins is enough or not. And this is my fear. I'm not sure, we will see, but I'm not sure that the reproducibility in low volume centers will be the same than for cryo. This is except maybe if we use systems with mapping and kind of further evaluation of the isolation of the vein. But we should be a little bit cautious on that.
Any question? I have one. In your clinical practice, how do you select patients for roof or not roof by cryo? If you do this in all short-term persistent or in some selected paroxysmal?
No, for the paroxysmal, I never do, usually, except if I have a very good reason, but it's, let's say, maybe less than 1%. So I am not doing for the paroxysmal. For the short persistent, I'm doing for all. Because I think that it adds, it really adds something. It's fast, it's safe, it's not very difficult to do. We will do a case, I think, this afternoon here, if I'm not wrong. We will do a case together here. So you will see that it's going fast. It's not something that is difficult to do, and it provides more than PV isolation only. And at least, yes, I believe that for short persistent is interesting.
Do you have any data on durability of this roofline? Because you probably did a lot of redo procedures by different technologies.
Yes, we have made a presentation. We didn't make a paper on that, but we made a presentation, I think, 3 or 4 years ago at HRS about the durability of the roof line in patients that had redos. So with a 3D map, we could assess the persistence of the roof line, and it was in our data, if I remember well, about between 70 and 80% of roof line persistent, which is not bad.
It's not bad because
it's not bad.
It's difficult to do by radio frequency.
It's better than the radio frequency,
definitely.
no doubt, because with radio frequency, it's much lower. It's very, very much lower.
Maybe the reason for low efficacy at posterior wall is that posterior wall is like convex because of descending aorta, because of spine, and the balloon is convex the other side. So the contact zone is probably very low in the middle of the posterior wall, compared to roof where there is concave.
Yes, for me the balloon fits very well for the roof, because you have the left atrium that is pushing the balloon, and in fact it fits. It goes exactly where you want, and when you see the image that I showed of the posterior wall, in fact, only with the veins, you are doing at least half of the roof, only with the veins. So with 2, 3 extra applications, you may do it completely. I do a little bit more because I am a little bit obsessive, so I'm doing usually 4 or 5 to be sure I have no potential. The main difficulty that you have with the roof is that it's very difficult to prove by pacing only. If you want to prove that you have a complete roof, you need to do a 3D. Because if you do the pacing maneuvers, the line is so large that you cannot really pace. You need to place a catheter very, very low, which doesn't mean anything. So pacing maneuvers for the roof are not really efficient or reliable. However, in the first patient, we did a 3D map to assess the roof line. In the first maybe 10 or 20 patients, we did a 3D, and we saw that in all patients we had a roof line. Then the durability is something different, but acutely we could assess that it was really efficient.
Did you try to do anterior line, because that could be also suitable for that, because if you start close to mitral valve and then just pull up.
Yes, it's a very good point and a very good idea. I've tried in patients having a substrate that we did a 3D map, and then we saw that the roof, the anterior line was quite diseased, the anterior wall. So we did in few patients. It's very difficult to obtain a good stability on the mitral site. It's okay for the posterior part of the anterior line. It's okay. It's not difficult. However, the more you're getting to the mitral, the more it's unstable. And this is not easy to do, honestly, because you need to have somewhere to anchor. It's not the balloon like putting like this. You need to anchor somewhere. Usually for the roof, we anchor on the veins. we place the mapping catheter on the veins, and then we rotate, and we can push really well. For the anterior line, it's not easy to find a place to anchor. You cannot do it in the appendage because it can be dangerous. And this is not easy, but it would be perfect, yes.
And what is the time for a single shot for the roof and the nadir or desirable temperature?
Yes, this is an excellent question. Between you and me, but please don't tell to anybody, I don't know. No, our experience showed that with 3 minutes for each application was enough if you had a very good stability, which is, as I was saying, quite easy to obtain a good stability. The temperature is another problem because you are not occluding anything. So a temperature of -50, for example, in the veins, doesn't mean anything on the roof. Usually, in my experience, you obtain, if you have a good stability, a good push on the roof, you are somewhere between -40 and -50. For me, this is the goal, to be between less than -40 and between -40 and -50. Another point that I want to add, maybe you saw in the pictures I showed, we place a probe in the esophagus, because when you are doing a roof line, you cross for sure the esophagus somewhere. So if you are only doing the veins, the temperature in the esophagus is not, in my opinion, necessary. However, my German friends would kill me if they hear me, because they think that it is. But okay, I'm not doing, let's say like this. But for the roof, I think it's important to have a probe in the esophagus, because you sometimes you have a really very important decrease in the esophagus, and this is a way, and that was a way for me to understand that cryo was really also efficient on the roof, because when you see that you are decreasing the temperature in the esophagus while ablating the roof, that means that you are transmural. And very often, always, you decrease the temperature in the esophagus until at least 15 degrees Celsius. So that means that you're really, really transmural when you're doing the roof. And this is another indirect way to understand that you are doing something on the roof, indeed.
Serge, just a comment. I think that cryo, still just for PVI, I agree with you with the roof line. We tried sometimes to do the left posterior wall, but really and truly, I don't believe that the best tool just to do it. And there are very few reports in the literature that you might promote atrial stiffness if you go with the cryo extensively in the left posterior wall. So really and truly, I support just for PVI, not more than that.
Yes, I agree.
All right, thank you.
Thank you very much.
Thank you very much. And the lunch is waiting for you, for us as well. And we will reconvene in 1 hour time, exactly at 3 p.m. for live cases.
Thank you very much.
Thank you.